Hey, folks, if you haven't done so already, please click that subscribe button below. That'll help us grow as a show, attract better guests. Together, let's make healthcare better for everyone. Once again, click that subscribe button. We'll see you on the next one.
Get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Kober. I am your host, and I'm delighted to have with us today Jolee Perez, who serves as the Director of Employee Benefits for the City of McAllen, Texas, where she leads efforts to ensure city employees receive high-quality, cost-effective benefits. With a commitment to public service and a focus on employee well-being, Jolee brings deep expertise in benefit strategy, compliance, and workforce support to one of South Texas's fastest growing communities. Welcome to the big show, Jolee.
Thank you. Thank you very much.
So great to have you here with us. So I actually came across you at a conference where brokers and employers and business leaders get together to focus on, all things benefits. And it's the Free Market Medical Association. It was out in Oklahoma City, hosted by some great folks, the leaders of Surgical Center of Oklahoma, and a big TPA out there. And essentially, they're bringing together a bunch of like-minded folks who are focused on looking at healthcare as an employee benefit that really, let's face it, there are two pieces at the very least to considering working someplace, right? Everybody's got to have a job pretty much. And you're focused on, okay, well, I need money to pay my bills and put food on the table and take care of all of the necessities. But the other kind of short runner up, I think, is what is the healthcare like? What's the employee benefits package like? And it's becoming a bigger and bigger consideration. And when you consider that healthcare now, according to the Kaiser Family Foundation, if you look at the average cost per household, it's averaging just around $17,000 per employee per year. That's the national average. So it's a huge expense, typically top 1, 2, or 3 after payroll. And I would imagine you're responsible for a few lives out there in McAllen, Texas. And I think this kind of got your attention because you were looking for ways to, or let's just say you're looking for alternatives, kind of doing your job saying, are we doing the best we can here? Could we do something better? And, give us a flavor, like how did this get your attention? And just share with the audience, what type of a workforce are you responsible for?
Sure. So we have about 2,000 people on our workforce on an average, and that includes all the full timers that are eligible for our health plan. Our health plan has about 3,200 lives on it, and we had suffered quite extensively post Affordable Care Act in trying to control costs, and we were trying to find new and inventive ways to change the trajectory of where we were heading. And so, Free Medical Market Association has like-minded people trying to just break the box from the norm, trying to find something new, something innovative, and it
Wait,
really is.
I like that word. Did you invent that? Innovative?
Yes.
It works, actually.
And
right,
so
trademark that.
right. And so it really was a great conference to bring all these experts together and be able to brainstorm and be able to hear success stories. And we were able to share our story with what we had done with our health plan. And it was exciting to be there with so many just wonderful people that are in it for the right reasons and want to do the best for their employees and their plan members, and not give in to traditional healthcare money flows.
Yeah, for sure. So give us a flavor. How many employees are you responsible for?
About 2,000.
About 2,000. So 2,000 employees, plus their families. I would imagine that's over 3,000 lives,
Right.
somewhere in the 3 to 4,000 range that are actually covered on plan. And that bears with it a great weight of responsibility. And I think you'd agree most HR professionals take the business of healthcare very seriously. What was it about what you were doing prior to what you did that kind of got your attention? What was kind of that moment where you said to yourself, and what were you doing before you made the moves that you did? Because you were one of the featured speakers at the conference, and you were there to kind of share your story. So, if you would kind of take us back to when you got into this role, what were you looking at? If you could describe your primary function, like what were you tasked to do when you landed in the role, and how did that evolve, and how did this eventually get your attention and get on your radar?
Sure. So when I got in the role about 15 years ago, it was a little bit different of a position. It was more reactive than proactive. And so we counted on our brokers a little bit to be giving us the direction we needed that would help us maintain control of our costs of the health plan. And as we saw that wasn't working, as we saw that staying the course to what everybody else was doing wasn't working, we saw our surplus diminish. We had a $5 million surplus at the time, and it completely went away. Our controls were getting tighter. We had all of the controls that were being recommended, whether it was on the medical side, on the pharmacy side, and we were even being slightly progressive towards my 5th year in. We were contracting direct clinics to try to have a discount from what our contracted rate was under our TPA, our carrier. And so that was helping us a little bit, but again, not making any big moves. Meanwhile, we were cost shifting. We were doing a lot of cost shifting to the members. And so that was coming in ways of co-pays and co-insurance, as well as premiums. Our satisfaction was dropping dramatically. The running joke is that, I was afraid to go to my car at night because I was worried that, somebody might have slashed my tires. And I know it's a running joke, but there was a real fear because we had such dissatisfaction among our membership at the time. And so that's when we knew it wasn't working. Following all of the recommendations, doing all the tight controls on the plan, it still wasn't helping us. And even though at the time we were better than book of business, and our TPA would show us that we were way better than book of business on medical, the same thing with pharmacy, it still wasn't changing the budget. And the budget for the City of McAllen affects our taxpayers. So it's not only premiums coming from our employees, but it's taxpayer money. So it wasn't making a difference on the overall budget. Something had to change.
Yeah, and that's the example that you lay out, the visual of just being afraid to walk to your parked car in the employee parking lot at the end of the day. It's kind of funny on one hand, but it's also real on the other, because you're really messing with people's lives when you mess with their healthcare. And I think that's why so many folks in your position, it's super easy to just keep the status quo going, right? If you're not changing anything, you're not rocking the boat. That's a big
Right.
motivation to just, and I'm not saying that this was you, but bury your head in the sand and just kind of do what everybody else does. Rely on your broker, typically a big box broker. No one gets fired for hiring IBM, right? That's the old adage. And so if you just keep things the same, that's the safe bet. But in your view, that wasn't really the safe bet, because you experience. And how did you said that there was dissatisfaction. Was that from surveys or polling or just word of mouth? Do you actually measure how employees perceive benefits? How did you know?
We had an internal survey that we do every couple of years, and that was very reflective of the satisfaction levels of the employees. And then we just have a very open door to members coming in, whether that's the employee themselves or their family members. And so we were hearing complaint after complaint. We were hearing, I can't afford this medication anymore because of the copays. I can't I can't get this approved because the plan controls are so tight that, you know, everything I'm trying to get approved isn't coming through as approved under the plan. And so we would hear all that feedback direct from the members as well as through the survey.
Yeah. And so I could imagine it must have been concerning, to field those calls because people are reaching out to you for help saying, this is unaffordable for me. And most folks are not in the know, right? But the studies show that most American households have less than $500 or $600 saved for a rainy day. And so we've experienced over time this. Again, if you look at the charts that Kaiser Family Foundation puts out there, the increases in premiums, the increases in deductibles outpacing wages and inflation, folks are effectively working more for less every year. And of course, that's going to lead to dissatisfaction, but not only dissatisfaction, I would imagine desperation if they're in a position where they need care and are functionally uninsured. And traditionally, that's been the broker blueprint, right? The brokers have been trained, and the large, big box brokers, particularly the ones with skyscrapers on, 6th Avenue and Manhattan and, scattered throughout the country. They own these big buildings. They're multi-billion-dollar corporations. Healthcare is working just fine for them because for years, employers have just kind of resigned themselves to, well, the increase is coming. There's nothing we could do about it. They bought into healthcare's big lie. You can't control the cost of healthcare. And so the model has traditionally been the broker comes in and spreadsheets a variety of different insurance carriers. You hear from the TPA, you're doing better than, than your peers, et cetera. And it's very easy to, swallow that pill and say, well, we're doing a good job. We're doing the best we can. But something caused you to question that. And I guess what was the aha moment for you where you said, I think we may be able to do better?
I think being introduced to an alternative and being able to see the vision of an alternative. And in our case, it was direct primary care. When I first fielded the call, I got a call from actual insurance peer of mine. He called me and he's like, I've never asked you to take a call before, but I really think if anybody's going to take this call, you need to hear about it. And so, I took the call, had them come in person, do a presentation. And by the end of the presentation, at the time that I heard the presentation, I was at a point in my career where I was very cynical that I would ever be able to make an impact and that we would ever change these numbers. The hill was just climbing, never saw it going down, never saw an opportunity to be able to have a success story. And so I took this meeting, and by the end of the meeting, it was like a revival had happened. I suddenly saw that there was another way, and there was a light at the end of the tunnel, and we have an opportunity to make an impact that not only would change the financial aspect of what we were doing, but it would really have an impact on our members, and it would be able to have an impact on our satisfaction levels with the members, as well as just knowing that we could change lives this new method. And so for me, direct primary care was the big aha moment where it not only changed my perspective of what I was doing in my career, but it gave me a purpose that was going to push me forward for the next decade.
Yeah, that's wild. So for folks that aren't kind of in the know, direct primary care kind of goes back to the days of yesteryear, right? Where folks actually have a relationship with their physician. And instead of having a model where, it's like a box of chocolates, you have a huge, network, quote unquote, and you could pick from any doctor that's in your network, right? Any provider that's in network. And generally then your plan kicks in and there's coinsurance, you pay a portion, the plan pays a portion, there's co-pays and stuff like that. With the direct primary care model, think more Netflix, right? It's a subscription-based model. And generally speaking, the advantage is the physicians have a much they have much less of a caseload, which then empowers them to spend more time with you, the patient. And it leads to a more intimate relationship and an understanding of what you are going through physically. They understand much more deeply who you are as a patient, what makes you tick, what makes you sick, and ultimately they then are your point person. Generally speaking, there are many iterations of direct primary care, but in the most successful models that I've seen, and you could tell us a little bit more about yours, the direct primary care physician then acts as someone who is going to refer their patient to a specialist in situations where they can't take care of the patient. And actually, the best direct primary care providers, I think, are they're very good at many different disciplines. But if it boils down to an actual specialty, if maybe you have a musculoskeletal issue, then you're going to be referred out to an orthopedist, for example. But generally speaking, in the models that I've seen, the direct primary care providers actually then kind of curate, and maybe with the assistance of a medical management team, but they curate care so that you're not just picking from that box of chocolates. You're actually going to a provider where the quality scores are good, meaning they do a lot of these types of procedures that typically results in economies of efficiency, which results in high quality care, generally speaking, the lowest cost. The plan wins, the employee member wins, everybody wins. How exactly does your model work?
Sure. So much like you said, we start with the relationship between the direct primary care provider, who on average, instead of traditional care, would normally have about 3,000 to 4,000 people on their panel. Under direct primary care, they only have between 500 and 700 on average. And so that relationship is built. And when there are referrals, they are not only referring them to the high quality providers, but there's also a cash pay negotiation that takes place. So instead of paying 200, 300, 400% of Medicare on a lot of these services, we're actually able to, pay 100 and 125% of Medicare. So that dramatically cuts down our expenses on those referrals. And that includes things like imaging, as well as labs, or even surgical, the bundled surgeries that we're getting into. And so with our setup, what we do is the member has no cost liability from the time that they enter the direct primary care all the way through the referral process to any of those ancillary or surgical or imaging providers. Therefore, with the access that they have through the direct primary care, 24-hour access for emergencies, as well as just ongoing text and email capability, they have the ability to take the biggest hurdle of healthcare, which is access, and that's been eliminated under this model. And then we've removed the financial liability, which is that second hurdle to healthcare. That's why people don't go. They can't get in, and they don't want to wait 2, 3, 4 hours at their traditional healthcare providers. At direct primary care, that's all eliminated. When they have a 10 o'clock appointment, it is a 10 o'clock appointment, and they are getting seen at 10 o'clock. If they need the access through text messaging or virtual visits, they have that as well. Whatever's convenient to the patient. As far as the financial liability, you're talking about, instead of spending anywhere from it could be as little as $500 a year to some of these people could be spending $6,000, $7,000 traditionally a year under their medical plan, and that's all completely eliminated under the model that we've set up.
Yeah, that's amazing, right? So if you think about a traditional health plan and you think about the way that it's set up, you go out to set an appointment, and in the New York City metro market where I'm from, if I want to set an appointment with my primary care physician, maybe if I'm lucky, I'll get an appointment 3 months out, but it's not unusual for there to be a 5 or a 6 month wait. And if you think about the cost of health insurance, being somewhere in the $30,000-$40,000 range on average for family care, if not north of that. I've seen plans north of $70,000. The idea of not being able to access care because the queue is that long, the the line to get in is that long is absurd. And direct primary care turns that model completely on its end. So it's not only about efficiencies of dollars and cents, right? It's not only about saving dollars to the plan and saving dollars to the members. It's also about creating access to care, which is a big piece of this. And ultimately, it also is about giving the employee a gateway to $0 out-of-pocket care. And if you look at our health, if you look at a health plan and you break it down mathematically, it kind of follows Pareto's rule, right? So 20% of your members are driving 80% of your costs. And the top 1% of your claims are they drive about a third of your costs. And we call those the super utilizers. Now, if you have someone that's an employee of the city and they're out there working and they might be, fairly new to the game, or they may be veterans, getting ready for retirement. Either way, if they're, the unlucky winners of a lottery ticket that deals them a terrible hand medically, no fault of their own, but they have medical issues that require a significant amount of care, they may make up that 1%, the super utilizers. And the way a traditional health plan is designed, that means that they're butting up against their max out of pocket costs every year. And so now if you look at our plans, it's for family coverage. I believe the 2025 max out of pocket is around $20,000. That's a fortune for a city employee. It's a fortune for most folks, right? And essentially what that means is they're functionally uninsured, or they have insurance, but then they're going to be responsible for the debt that they accumulate to cover their fair share. And this leads to bankruptcy. The number one cause for bankruptcy in the United States is medically related. It's, folks, medical debt is the number one driver of bankruptcy in the US. So in solving this problem and diving in, Jolee, you've kind of managed to, kind of kill a few birds with one stone, reducing costs, improving access and quality to care. It's got to make you feel pretty damn good about, what you're doing there.
It absolutely does. I like to tell the story that I knew we were making a difference when shortly after we launched the program, I was leaving a director's meeting one morning, and another fellow director, one who, quite frankly, I didn't think liked me very much, comes up to me and gives me this big hug. And I was kind of like, oh my gosh, what's about to happen here? And, it turns out she's like, you don't understand how much you've changed things for my family because of what you've done launching the direct primary care program. And that was a monumental moment for me, when I realized that she was on board, that she had had a good experience, that she had utilized it the way that we wanted people to utilize it. That this was one of the first positive feedbacks that I had gotten directly from the members right after we launched. And that was probably only 3 months in, but it was enough that she had had so many significant things happen to her family in those 3 months that she really had the true experience of having that access and the removal of the liability of the financial situation. So it was really a great moment.
Yeah, and you could imagine if that's, one of the directors coming up to you, how many other lives have you affected and touched? And they're folks that, you just probably never heard from them, but that's a ripple that's going, across the entire organization. And it pays dividends, because if you have folks that feel secure and cared for, they're going to stick around. They're going to persist. The retention of the organization is going to be better. It's going to be easier for you to attract folks, to the organization, because word is going to get out there that the benefits plan is solid, and it pays dividends. So great job, to you for taking notice. The Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, And yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit Benefixa.com. Now, I'm curious, though. On the other side of the coin, you have you have a broker, and the broker didn't bring this to you. I don't believe they didn't. Kind of present the direct primary care model to you. It's something that you came across when you went to FMMA. Is that right?
No, it was because somebody had brought it to me. Again, a peer had given me a call that they had gotten familiar with it and said, if there was somebody in the industry that could understand and have a vision for it, that they believed I could. So they brought it to me.
Yeah. So how was that received by your broker?
I had to explain what we were looking to build with it. And, she was very, very much on board. She saw what we were trying to accomplish and was very supportive, thankfully.
Oh, that's important, because it might not have went that way.
True.
Part of what I do is pull back the curtain on, not only there's plenty of good in the industry, there's plenty of good in healthcare, but there's also a dark side, to be 100% clear and transparent.
Mm-hmm.
And the reality is a lot of the large brokers have decisions like this made at higher levels. So even though the face of the brokerage might be someone who you consider a friend, who, you care about them, they care about you, it's a trusting relationship, that associate may not and probably is not calling the shots for the organization. And so when an organization like yours makes a decision to break away from the status quo, which essentially direct primary care is, that typically would not be received well in the boardroom, because it means it's coming at a cost to their bottom line. One of the drivers of their revenue is baked into a traditional health plan model. And when claims go up, then premium increases are likely. Premiums increase, compensation for the broker increases. And then within the healthcare system, you also have a whole myriad of services that are being provided that are, the status quo is kind of fueling that fire. Because if one of your employees are going to a primary care physician that's quote unquote in network, that primary care physician is affiliated with the health system. They then refer within the health system. That drives revenue for the health system. It drives revenue for them personally. And I'm not saying that, by and large, doctors are making these referrals for nefarious reasons, right? But there definitely is a infrastructure that rewards them for making referrals into their own system, and they're certainly under pressure by management to make those referrals. And so when those referrals are made, typically the health plan, City of McAllen, is paying the most that they can possibly pay for that good or service. And so I'm just curious, did your did your journey kind of end with direct primary care, or are there other cost containment strategies that you've deployed kind of since that? That was, I'm guessing, the first domino. What else are you doing to control costs?
So we've definitely grown the cash pay negotiation using our DPC provider as the conduit for that. But one of the other things that we've done is international sourcing of our pharmacy. That, alone in 1 year saved us almost $600,000. Just, taking the same drug that people were getting from the local pharmacies and sourcing them through international, which we also gave a rebate for the first year of our employees filling it through the international pharmacy. So there was an incentive for the employee, and we were getting anywhere from 30 to 70% discount on the pharmacy fill itself. We continue to look at things, in plan design, making sure that our overall strategy is consistent with, again, trying to make sure that the access is there, making sure that the financial liability is at its minimal that it can be for the plan member. But right now, I think, the turn of events with the direct primary care, that's where we're seeing the financial savings right now. And so we're definitely continuing to, reach out to those that haven't used that program yet. We're running at about 66% increase in primary care utilization since we launched. We have about 60% on average of our members that have utilized the direct primary care in some way, including the cash pay negotiation for the ancillary or the referrals. But really, monetarily, that's something that we're really focused on with the DPC and that program right now, strictly because we're seeing things like a 4% decrease in medical spend by the second year, which that was against inflation. That was just unheard of for us. We haven't seen it go down in the 15 years I've been here, except for that second year of the program. The numbers are pretty dramatic when we look at our trend. When we looked at what we were trending prior to the launch of that program, we were trending at about $561 per member per month spend. When we trended that out, where our trajectory was heading versus where we ended up, that delta shows us that over the first 2 years of the program, we saved $8 million, more than $8 million actually, just north of that.
Phenomenal.
So, this is definitely where we have to focus our attention right now. But we're definitely looking at some potential things with pharmacy overall, because we still have a major PBM right now. So over the next year, we're going to be looking at some possible things to do when we go out for RFP that will be new to the city, very much so. And so anytime we have something completely new, we always have that little bit of fear, right? How's that going to go? How are people going to take it? How are we going to work with the new vendors and things like that? So we're pretty excited to look and see what we're looking to do with pharmacy in the next year, but that's on the horizon.
Change is always difficult. I said if you give each employee a gold bar, someone will manage to complain. It's too heavy. I wasn't expecting it. I almost tripped over it. There's going to be something that negative that comes out of something great always. But change is, difficult in the beginning, messy in the middle, and beautiful at the end. That's my experience with change. It's something that is required in healthcare, because if you look at and you map out the trajectory of where the increases are going, it's certainly unsustainable. $5 trillion a year is where we are, 20 cents of every dollar that we're spending. And so, kudos to you for taking the initiative. So I want to understand a little bit more about your plan design, because you said, so when you first introduced direct primary care, did you give employees multiple plan options with direct primary care, without direct primary care? And does that, continue to this day? Do they have the option to choose their plan, one with, one without? And what did the participation look like in the beginning versus where it is now?
So what we did prior to direct primary care, we actually had two plans. We had a base and a buy-up, and we had some adverse selection going on. So it wasn't actually benefiting us to have the two plan design. So when we decided to launch the DPC program, we said, you know what, let's go down to a one plan design where anybody who enrolls in the health plan has access to this. So it's not a optional buy-on. It's not an added plan that they have to choose. It's if they're enrolled in the health plan, they have access to this. And we didn't want anybody who was enrolled in the health plan to not have access to it, because we saw the benefit of what it was going to do. And so we went to the one plan design. We went through open enrollment that year. We had a massive implementation plan, which included 100 separate department meetings where we had an hour-and-a-half session each with every single employee to explain how this was going to work, what the benefit was to them, and to help them really have the vision of what this was going to look like for them and their families. And so we went through open enrollment, and we had encouraged everybody, hey, don't wait till you get sick or don't wait till you have something come up. go ahead and schedule that first appointment to get to know your provider and have them do your health history, and so they can have all that on file, so that later when you have something come up, they've already got all that and they already know who you are. Looking back, I probably would have done that in stages, because we ended up having so many people call and make the first appointment that the first 4 months of the launch, the direct primary care providers were all packed. Every day their sessions were all booked up. And so we were trying to triage the emergencies in between there, trying to help everybody know, yes, you can still get with your provider, even though they look like they're booked today. It's just, are you sick? Tell me what's going on so I can get you in there, because we have to, get those through in between the introductory visits that were already scheduled. So looking back, we probably would have done that in stages so that we didn't have everybody jump aboard at once. But it was an incredible launch. I mean, people were complaining that they couldn't get in that first week for that first appointment. And I was like, okay, calm down. We have 3,200 members to get through, and there's only so many hours in a day. So,
Right.
we had that, but it was a good problem to have. It really was. It was showing that they were getting it. They were getting the vision of what could be, and they were excited about the change. So definitely a good problem to have. And like I said, we ran the first year right off the bat. We were at 65% people utilizing the plan. That has stayed consistent, and our NPS scores are still at 95. They run 95 on average, 95 to 97 at best. And so that's, again, showing that they're still using the program and that they're still happy with the program.
How does one measure that net promoter score when you say 95 to 97? What does that mean? Do you even know? I'm not sure.
Yeah, it's part of an exit survey that gets done, and it just, rates their overall satisfaction as to whether they would continue to use it and recommend it for peers. And so, when we look at NPS scores in the medical industry, your big TPAs, most of them have a negative net promoter score. It's actually like negative 50 to negative 100 on the net promoter score. You have companies that are great, like Apple and Google, that are running 50 to 60% on a net promoter score. And so to see 95 is just incredible as our average,
Sounds
from the
unheard of
population.
based
Yeah,
on what
we're
you shared. That
satisfied.
sounds incredible. I would say
Right,
so, for
right.
sure. So that's pretty cool. So you have a one plan design, which means you're paying a subscription fee, essentially, for lack of a better word, for every employee to utilize direct primary care, and your satisfaction scores are through the roof. You know that it's working. What's not to like? So I guess let me play devil's advocate. Have you had any horror stories? Has anyone, without naming names, had a miserable experience? Because I know you heard about the miserable experiences.
You know,
Anyone really comes screaming bloody murder like this was the worst decision ever?
we hear the things that we hear are generally people that have a misconception. So, somebody who wanted to get in today because they were sick, and when they looked at the schedule, it looked booked for the provider. And so they thought, well, I can't get into my provider today, and I was told I would have access to my provider. They do. They have that access, and they should have text messaged or called the provider to say what was going on, because then the provider has the ability to slide them in the schedule. There are open bookings for people to see and book themselves, but there are also time slots that are actually blocked so that they could triage people who might be sick that day, and maybe they got to come in for a COVID test, or maybe they're just not feeling well for whatever reason. And so the education falls on us, the benefits team, to educate the members to say, hey, when you need something, reach out to your provider, period. And when you text message or you call your provider and say, hey, I'm sick, I need to get in, that provider is then going to take everything that they can do to get you in that day, to get you taken care of. And so if you don't communicate to them and you're just looking at the schedule, yeah, it's going to look like it's booked. So we get those people that haven't taken that step to contact their provider, and they're like mad because they couldn't get in that day or the next day because it looked booked. We've had some situations where a visit or communication flow didn't go perfectly, and that's going to happen. We're humans. People have different expectations when they're communicating. They have different levels of listening and taking information in. And so every time something like that happens, we make sure that the customer service team with our DPC resolves that matter and reaches out and really tries to help. It might be a little bit of education. It might be just saying, hey, we messed up. This person was new and didn't know that they should have communicated this to you. And so there's an ownership that the DPC takes, that they truly own every one of those situations where it didn't go to the perfect experience. And so that has helped in those situations. But I will tell you that these are far and few between stories, because, in general, if somebody's following the program and the communication and reaching out and expressing what's going on, then things are getting taken care of in a great, scenario that generally, when that person is comparing what would have happened had they gone through traditional healthcare, they're like, oh my gosh, I got to see my provider in a timely manner. I got to come into my appointment and it started on time. I didn't have to wait in the lobby for 3 hours, only to see a provider for maybe 3 to 5 minutes. I was with them for 45 minutes and they got to, really figure out what's going on with me. We got the prescription sent right then on the spot, so those are the
overwhelmingly
stories.
positive good news associated
Right.
with the move, and very few, I wouldn't even call them horror stories, but kind of more misunderstandings about how the whole system works.
Right.
It's amazing what a difference, the correct, having the DPC model working for you efficiently in a health plan is a game changer, in my view. And the way that you've laid it out, I think, is really good, because your folks are overwhelmed when it comes to open enrollment. There's typically a ton of decisions for them to make. And I've seen organizations out there with dozens of options for health plans. It really is confusing and overwhelming to even someone like me who's a seasoned veteran. I have children that are grown and they're out there in the workforce. And they ask me about their benefits options, and I can't imagine how people navigate it without having in-depth knowledge, because it's crazy. So to be able to distill it down to one plan option, because I'm sure you offer, plenty of other benefits that they have to have an understanding of, but to distill your health plan option down to one, I think that in and of itself is terrific. And then to have DPC as the cornerstone. And what I'm hearing is you're not taking anything away, in that if an employee wants to access a traditional, health plan, I would imagine you have a major insurance carrier backstopping your plan. They can access, that as if they choose to, but then they're going to be responsible for their out-of-pocket expenses, in which case you have a path with utilizing the DPC model that gives them $0 out of pocket. Is that what I'm hearing?
That is correct. And we think that was the best way to launch, because exactly like you said, we weren't taking anything away. We were only adding to the experience and giving them that outlet. And so, I said we're running about 65% on average of utilization. We still have 35% of members that either aren't going for care or are going to the traditional healthcare providers using a fee-for-service model. Some of those are just people that, they've known their provider for 20 years and they think that their provider has their best interests at heart, and they have a relationship over those 20 years.
Sure.
My question to them is, if you stopped coming, would they call you and say, hey, where are you? We miss you. Come and get your labs done. We're worried you haven't had a physical.
Right.
And it's funny because the number of people that say, oh, no, they probably wouldn't. I usually say, well, that's what you're missing under the direct primary care model, is somebody who's actually, looking out for you and trying to make sure that you're getting done what you need done.
Yeah.
But we definitely feel like that was the best way to launch the program. And again, back to the two designs where they have to choose. If I believe in this program, if I believe in direct primary care and I believe in everything that it can do for the member, why would I want to have a portion of the people covered under a plan that don't have that option?
Yeah.
I can't see the rationale there, because it's not doing anything for the member and it's not doing anything for us, the plan.
Well, I'm going to put you on the spot, and you don't have to answer. But what plan? What path do you choose?
As far as going through the direct primary care,
Yeah.
well, of course I'm there.
I mean, couldn't that say it all? This is what you do for a living. Like
Right.
you're the chief architect of this plan, essentially, and that's the path that you take. So that speaks volumes.
Right. And I did have a provider that I thought I knew very well that I had used for 15 years. And as much as, it was sad to see, me go this route, I knew everything that was in it for me and I knew what was in it for my family.
Yeah.
And so, I had to do what was best for me and my family.
100%. And so does the DPC also offer virtual teleconferencing and
Yep.
phone consultation, or do you have to show up to a brick and mortar facility?
No, it has all of those options. So, you can get things sent, your lab results sent to you by email. You can have a virtual visit over them if you want to talk about them, or you want to get a summary via text. You can get that way. It's whatever the preferences of the member. And we have members that are technologically savvy, and we have members that are not. So the members that are not technologically savvy, they prefer those in-person appointments.
And what about pediatrics or OBGYN? Does the DPC handle that as well, or is that outsourced?
Yes, they do. So they do both women's healthcare as well as pediatrics. The one thing that we're growing in is the fact that we haven't been able to sustain enough of the pediatric vaccinations. So while we can do all the pediatric care, the vaccinations right now are something that we're trying to see if we can do a campaign on to remind people about, that we can do pediatrics so that we can actually sustain enough to have the inventory of the vaccines on hand at any given time.
Wow. Very, very cool stuff. And so let me ask you, what do you see for healthcare moving forward? If you had a crystal ball and you said, well, here's where I think the country is heading, and here's where I think we're heading, because we have somewhat control of our own little ecosystem. But what do you think the bigger picture is? If you hadn't gone down this path, I think you said there was 8 million in savings over the course of the past 5 years. What do you think that'll look like 5 years from now?
Yeah, I mean, I can only assume that savings trend is going to continue, and I'd actually like to see it even grow further. Just again, trying to attack that 35% that's not utilizing the primary care at this current time. As far as the crystal ball as to what healthcare is going to look like, I see us fighting for more transparency. I see there being such an angst and anger towards the fee-for-service model, and especially on the PBM side, the money that is flowing into so many places that we don't get to see. And I think that you're going to see a real change coming in the next, over the next, I would say next 4 or 5 years, where people just get out of the model altogether, and they go cash pay, and they find other ways to bundle things that don't include this, especially on the pharmacy side, muddy waters of where all the money is going. On the medical side, it's a little bit more clear where the money is going, but under the fee-for-service model, we're not going to be able to make a dent, and so I see that model going away.
Yeah, that's I don't disagree with you. I think something somewhere has got to give, and we're at a point where if you're just following the status quo rules of the game, you're setting yourself up for failure. You're certainly leaving a lot of money on the table. You wouldn't know about the 8 million in savings had you not taken the action to begin with, right?
Right.
And so I think you always have to be on the lookout for, are we doing the best that we can? And now under the CAA passage of starting January 2021, you have a fiduciary obligation to do so. So I think you're ahead of the curve for sure. But so many of your colleagues, I think, are failing in that regard, not just HR leadership. I'm talking about all the way on up to the CEO of an organization. It's vitally important that they understand that this isn't, a game anymore. Like, you have a fiduciary obligation to your employees and plan members to spend plan dollars wisely. And you are ahead of the curve. You've kind of looked under the hood and you said, well, what could we do better? And it's gotten you where you are, which is tremendous. So hats off to you for doing an outstanding job. What would you suggest to any of your colleagues in HR that might be listening to this on a drive or tuning into our YouTube channel? What should they be thinking about as they look at planning benefits for 2026 and beyond?
I think one of the first things they need to know is they need to know their own contracts. I find a lot of my peers don't know how to read their contracts. They don't know where the money's going. They don't know the levers that they can pull and what they have control over versus, the things that are pressed upon them. And so I would say the first thing they need to do is to know their own business as far as where they're at today. And then, start challenging these things that they have available to them. And if they don't know what the levers are that they can manipulate and move within the system, then they need to get educated through other friends, other peers, podcasts like this one, or associations. There's some great associations out there with educational courses that can help them understand health plan management, and they don't have to rely on a broker and they don't have to rely on consultants all the time. They can utilize them effectively, but they don't have to rely on them for all of the knowledge, because there's too much control when all of the knowledge is outside of this position. If you have the knowledge within this position, you have a much better chance of making a dent and being able to do something effective for your organization.
Yeah, well said. Think about it, folks. 8 million in savings over 5 years,
That
and
was
they're
actually over 2 years. That was 2 years of savings.
2
That was
years. I
that was the
I
first 2 years.
I stand corrected.
Yes.
So if that's 2 years, that would be 20 million over 5 years, just
Yeah.
assuming all things are equal. So
Right.
that's being a city employer, you're returning that to tax holders, which is amazing, to taxpayers, right?
Mhm.
Which is amazing. But if you look at this in the private sector, and you're a business that is potentially selling at a 5x or a 10x multiple, look at the value that you'd create for your shareholders just by paying attention. And ultimately, um, I'm going out on a limb, but did you walk out to the parking lot and see that your tires were all slashed?
No, I know I'm getting the hugs. So
Now you're
no,
getting the hug. So it is possible, folks. I think the first step is just taking an interest and knowing that this has been done before. You're not you didn't invent the direct primary care space. You discovered it. And then you were intrigued enough, you had curiosity and you dove in, and you made the bold move to change, to, we're going to try this. We're going, after you did your diligence, and we didn't kind of jump into the shallow end of a pool, you know n- not knowing the depth of the water, right? You did your diligence, you dug in. And I'm sure that that didn't happen overnight. It took you some time to go through that, and look at what happened. Beautiful, beautiful things happened, and you're a great leader. So really, congratulations on um, doing an amazing job for the people of McAllen, Texas. I hope they appreciate you.
well, I know me and my family are on that same plan. So, there's I don't want to say self-serving there too, but I love that we're reaping the rewards both personally and professionally, to know that I'm helping everybody else that's utilizing this. It makes a difference. It revived my interest in doing my job, and really kind of reignited that passion for what I was doing. So.
Well,
That's a good
Jolee,
thing.
the employees of the city of McAllen, Texas, are in your debt. You're doing a great job, and we appreciate you for joining and enlightening our listeners and our viewers. Thank you so much for being here. We hope you'll come back and share more success stories with us in the future.
Thank you for having me.
Awesome. It was our pleasure. Folks, until next time, peace and love always. Take care.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.